work. Yeah. So the obligatory disclosure. The University of Wisconsin, where I work, owns the patent for intravenous Sevoflurane and also for a non-lipid formulation of propofol that we're working on. I'm not going to be talking about propofol on this, though. Another disclosure, I really don't consider myself an expert in this area. I'm much more an expert in mechanisms of anesthesia action and a neuroscientist in brain function. But there really are not very many worldwide experts on intravenous inhaled anesthetics. So I'll do my best to explain where I think the field is going and what we should be doing next if this is going to go forward. I'll talk first just a little bit about the motivation, the rationale for why intravenous anesthetics might be useful, intravenous inhaled anesthetics. And a little bit, not exhaustive, but a little bit about the early studies, more recent studies, and then our own studies, and talk about where we might go from here. And these are a few of the possible advantages to giving Sevoflurane or Isoflurane, the two agents that we've worked on, intravenously. These have been noted by other authors. They were the first immediately apparent things to us also when the possibility of creating nanoemulsions of Isoflurane or Sevoflurane came up. That it's very simple. Rather than having a vaporizer in a machine, just a single syringe that can be injected intravenously is quite easy. It can be applied in a lot of situations where you can't carry a vaporizer around with you, on the battlefield or in mass casualty situations or things like that. And it's a full anesthetic, unlike many of the intravenous agents that we have and have to give multiple agents to achieve all the endpoints of anesthesia. It may have a very fast onset, although, as we'll talk about later, it may not be instantaneous, at least not safely given instantaneously. Early on, the controlled delivery was a real motivation for some of the early investigators. And this was at a time when ether was given by open drop and it was not very controlled. Now controlled delivery is much more routine, but still intravenous isoflurane or halothane or sevoflurane can be very controlled. Some studies have shown remarkable hemodynamic stability with inhaled or with intravenous as opposed to inhaled agents. And one of the real advantages in terms of hemodynamics is if it's possible to have a very fast onset that can match the hemodynamics of a response to a painful stimulus or a noxious stimulus, for example, it may not be that it's more stable by the anesthetic, but the surgical response may be able to be blunted very quickly. And so that was one of my motivations when a surgeon's going to make an incision at the beginning of a case. You don't have to turn the agent up and wait for the blood pressure to go down for some time, and then suddenly it overshoots and we try to catch up. If we can match the hemodynamics very quickly, that could be a real advantage. Some of the more recent studies have shown that tissue protection is even better with intravenous inhaled agents than it is with inhaled agents. And there's the possibility for less waste, less environmental pollution if you have a closed system and you're just injecting this directly into the patient. So these are some of the motivations. Some of the early studies, this goes back more than a century. This is a German anesthesiologist, or surgeon, I'm sorry, Ludwig Burckhardt, who experimented back in the early 1900s with the administration of chloroform and ether intravenously. Now, these were dissolved. These weren't emulsions. These were dissolved. They had to give large volumes. They found out if they did that, though, they could have a very smooth induction, and it was more controlled than the open drop techniques that were used. Chloroform was dropped because of its toxicity quickly, but he had success with this, and he used it for primarily ENT procedures, where now he could have access to the airway without having to share the airway with the anesthetist, and that was a real advantage. Some 50 years later, the great Ted Eager also experimented with giving inhaled anesthetics intravenously, and he basically replicated some of the early studies of Burckhardt, and again applied it to ENT type procedures. Another real pioneer in giving inhaled anesthetics intravenously, or I should say volatile anesthetics intravenously, was a pharmacologist from University of Maryland, Dr. Krantz was the chairman of pharmacology at University of Maryland. He initially started studying volatile substances because he was interested in providing some sort of induction of seizures using Indoclon. And Indoclon had been given inhaled, but also he then discovered that he could give it intravenously. Seizures were being induced without any sedation at that time in order to treat depression, and this was a long time ago. Patients found that it was scary to get this inhaled agent, but they greatly preferred getting intravenous Indoclon. So he did that for some time, a couple of years experimenting with that, and then he turned his attention to methoxyflurane. And they had a real struggle getting methoxyflurane. Halothane and methoxyflurane were the only volatile anesthetics available at the time for human use. And they couldn't get methoxyflurane into a formulation without creating an emulsion of it. It didn't dissolve well enough, and even the emulsions took a long time. Methoxyflurane was apparently very difficult to do an inhaled induction with. I never have done that. But it took so long and a long time to wake up, and he thought that this may be an advantage of using it intravenously. They used lecithin as an emulsifier, and this was the formula that they had to make an emulsion. And I'll tell you a little bit about what emulsions mean as opposed to dissolved agents. Lecithin turned out to cause problems. High concentrations of this agent also caused phlebitis, and eventually it was dropped. It wasn't ever used as a widespread clinical use. But Dr. Krantz made some important observations that I think still are guiding us and are valid based on what subsequent studies have been. And that is that when you administer a potent anesthetic agent, you may be able to achieve a controlled delivery by measuring the concentration, and you can get a controlled delivery intravenously. Flammability was a hazard, and that's eliminated by giving intravenous. By ENT surgeons, it's preferred because they don't have to share the airway again. And in mass emergencies, he declared this might be a useful technique. He also recognized that for agents that have a high vapor pressure, a lot of it might be eliminated by the lungs quickly and excreted quickly, and so large amounts may need to be given. And these were given in very large volumes because they had limited concentration ability, and that became a problem. If the agent is low potency, a high concentration and large volume precludes its routine use. They recognize that if you give it intravenously and then have a rebreathing system, that may prevent you from having to give these large volumes, and that principle certainly holds true, and it's something that we haven't experimented with, but if it goes forward, I think that this is a useful way to deliver agents, is in a closed system, just giving it intravenously. And they found that they could successfully use methoxyflurane, and that was basically his conclusion. So not much was done for a number of years. There were some other emulsions tried and tested. Halothane was tested as an emulsion, and that was tested in several different animals. 5% by volume, I believe, by volume. Halothane was required or was created, and it was able to successfully induce anesthesia as an emulsion. Interestingly, the concentration of anesthetic in the exhaled gas that they were measuring was less with an IV injected at MAC, and that is MAC tested in the usual way with animals moving or not in an up and down method. And so it took a lower concentration in the exhaled gas to achieve an endpoint. Subsequent authors have measured the concentration in the blood, and the blood concentration is not different. So this reflects the unequal distribution, the cascade of drug elimination out of the blood into the lungs, and that we're measuring. And so being diluted by continuous ventilation, basically, is what this recommended. Isoflurane by emulsion has also been tested. And there were, in fact, a series of emulsified isoflurane papers that came out in dogs and in mice and in rats. This paper, though, showing the effects of emulsified isoflurane in rabbits, really created some notice. And it was primarily not because it caused anesthesia, but because it induced protection. And we're all familiar with hypoxic or anoxic hypoxic preconditioning, and that anesthetics can cause the same preconditioning. It protects tissues against subsequent damage. And anesthetics cause this, and they tested whether or not IV anesthetics might be able to cause it. They didn't really provide much of a rationale, but this was actually one of my thoughts when we first started, and I wasn't so familiar with this literature, is that it wouldn't be a very plausible way to have patients be preconditioned to bring them into the clinic and smack a mask on their face and have all these patients breathe sevoflurane for a day or two before. But it'd be much easier to put an IV in, and patients are lying there, or on the way to the operating room, you can continue to give them a little bit. So they may have been testing this IV formulation for preconditioning for practical considerations like that. And there was a editorial that accompanied this, asking whether this is a true innovation or old wine in a new bottle. They concluded that this actually may be a really useful new innovation because the conditioning was improved. It eliminated, and there are some practical considerations, it eliminated the needs for specific circuits. Anesthetic delivery was independent of the pulmonary function. Induction and emergence are rapid, and they found out that it was rapid even compared to propofol. They showed strong hemodynamic stability, and in this editorial they cited a lot of other studies showing good hemodynamic stability. It required significantly less isoflurane. At some point, the cost of anesthetics mattered. It matters less now that these anesthetics are generic. It's not a big part of the anesthesia cost, but at one point it was. And there's reduced environmental pollution. And it may be possible to deliver high concentrations of agents to allow protection of tissues, not just in vivo preconditioning, but actual protection, as in organ protection. So these are some of the advantages, as well as protecting endothelium, et cetera. So these were the key advantages that others had recognized already before we even got started. Ischemic preconditioning, or anesthetic preconditioning, I should say, organ preservation. It could be used as a cardioplegia additive. And these are some of the new applications that were proposed and had been tested, but not exhaustively. So these are just a few other possible advantages to giving it. So a summary of sort of prior studies is that it's possible to induce and maintain anesthesia. It's better done with emulsions because you can get a higher concentration than dissolved anesthetics. The anesthetic depth can be monitored by end-tidal concentrations. And this has been tried, and there is technology out there for propofol, I understand, but it's not available clinically for us to use. And this is really a driving factor that keeps people using inhaled anesthetics, I think, is that we know what concentrations our patients have. And so this will apply for IV anesthetics, sevoflurane, for example. Lipid emulsions, which is how all of the emulsions until now have been given, have some problems, undesirable effects. Large lipid loads are not good. They change coefficients between various drugs in the blood and the tissues, and they themselves can cause unwanted effects. But it may still be an economical way of delivering anesthesia. So with this background, I had been approached by a chemist, a synthetic chemist at University of Wisconsin who does fluorochemistry, Sandro Macosi. And he proposed making some encapsulated anesthetics using fluorochemistry. And I'll show you a little bit about what this has, but the Fluorous phase is a third liquid phase of matter. We all know about the aqueous and organic phase, but if you have Fluorous chemicals that are liquid, they separate, and fluorochemists use these as a way of separating molecules. They also have developed a lot of agents that have aqueous characteristics at one end and Fluorous characteristics at the other end, and they can be used as surfactants to encapsulate droplets or micelles to hold fluorinated substances in the middle. So we initially tested some micelles. Micelles can't hold enough anesthetics to do anything, so we turned to emulsions. And emulsions are dispersed phases. So the range is about 100 to 500 nanometers. In practice, people try to keep their size of the particles less than 400 nanometers for safety. They're kinetically stable, but not thermodynamically stable. What does that mean? They don't self-assemble as a stable system. You have to put energy into a mixture, and it breaks up when it comes back together. It may come back together with little droplets that are separated, but they tend to go back together. But it takes a long time. So that's what kinetically stable means. It takes a long time for these to separate, to segregate. They have a high surface area per unit volume, and that can lead to stability also. So a Fluorous nanoemulsion is an emulsion, and a lipid is an emulsion also. It has a phase that is contiguous, aqueous, and a discontiguous phase, which is lipid, little droplets of lipid. A Fluorous nanoemulsion has the Fluorous phase as the discontiguous phase. And Fluorous molecules can be both hydrophobic and lipophobic. So as I said, they don't mix. So in a typical situation, you would mix the, let's see, which of these? There we go. Mix water, hexane, and a perfluorinated molecule that's all fluorine substituting on the carbons for hydrogens, and let them segregate, and it segregates into 3 different phases. And if you use that, you can make a emulsion where the center of the droplet is a Fluorous chemical, Sevoflurane or Isoflurane or Fluorous. That then needs to be stabilized by a interface acting agent, a surfactant, and the surfactants that we use have chains that are covered with fluorine inside so that it inserts itself into the Fluorous phase, and then polyethylene glycol, an aqueous-like chemical, at the other end. So these are PEG Fluorous emulsions. Micelles hold very little, but the nanoemulsion can hold a whole lot. Nanoemulsions can be destabilized, and the way they're destabilized is shown here by creaming, that is, something can rise to the top or fall to the bottom. If you shake it up, it may disperse again. Flocculation, they may just stick together. Coalescence, one droplet might bump into another droplet and become a really big droplet. Or Ostwald ripening. And Ostwald ripening is the real problem with emulsions. In Ostwald ripening, something comes out of here, becomes soluble in the aqueous solution, and then it diffuses into a different one. And because of the difference in the pressure, a small bag will collapse quickly. A big one doesn't have as much surface tension. The same thing that drives that instability drives large particle size. So you have to stop chemicals from diffusing out of one particle into another. And the way that we did that was to add perfluorooctyl bromide. This is a Fluorous chemical that is essentially insoluble in water, 1 part in 10 to the 8th, I think it is. So it can't dissolve out of the center of these nanoemulsions. It holds the sevoflurane in there. The polyethylene glycol and Fluorous molecules act as buffers to keep them from bumping into each other and coalescing. So these can be stable for a year. So this turned out to be a really good kind of a formulation, and it was able to hold up to 30% by volume sevoflurane in an emulsion. So as opposed to the lipid emulsions, which were at most 5%, we could give much more concentrated agents, and rather than having to give 100 or 500 milliliters to a person to put somebody to sleep, you might be able to put a person to sleep with only 20 milliliters or 15 milliliters. So that's a real advantage, to have high concentrations of stable agents. So it becomes the possibility that it's a drug. So we started studying it, finally that we got a good formulation. We tested it first in rats, and in rats we tested it in rats who had implanted jugular catheters, so very consistent delivery. By the end of, this shows what the emulsifier is with 13 carbons completely substituted with fluorines and polyethylene glycol. We named it F13M5 because there's 13 carbons that are fluorinated, and M refers to PEG moiety, which has a molecular weight of, on average, 5,000, so that's about 120 PEG units at the other end of it to keep it aqueous soluble. And we tested that, and we found that it was effective at putting rats to sleep. It took about 0.4 milliliters per kilogram for these rats to put them to sleep. If we gave more than that, we could kill them. And the ratio of the ED50 from 0.4 milliliters per kilogram to 1 milliliter per kilogram, a safety factor of about 2.5, which is very similar to thiopental or propofol. Intravenous anesthetics also have this very small safety factor, one reason anesthesiologists remain in high demand. The duration of the loss of writing reflex was remarkably short when we put these animals to sleep. They went from not just losing writing reflex, but being completely areflexic, even to tail pinch or foot pinch, to being awake, walking around in a matter of seconds, and within a couple of minutes they were grooming, couldn't see that anything had happened to them. And here's an example of a rat that went in about 2 minutes from areflexic to completely awake. So with just a single bolus administration, it's very effective, but it has a safety factor that's low. We then tested dogs, and we tested dogs because we wanted to be able to instrument them more easily and measure the hemodynamics, what the effects were on cardiac output, be able to gather untitled gases more easily, for example. But we found with this administration that we elicited a high histamine release in dogs. Initially, we didn't expect this. We didn't measure histamine levels in our first dogs, but we saw evidence of it with puffed up faces and puffy eyes and drooling, and it looked to the veterinarian helping us with it as just as if it was allergic reaction. She immediately gave Benadryl, and the dogs recovered just fine. Remarkably, the blood pressure with this huge histamine release in one of the dogs went right down to about 30 millimeters of mercury and stayed flat for 10-15 minutes, no circulation at all. But finally, with some recognition of this and Benadryl, the blood pressure recovered and there were no adverse sequelae. And it makes me wonder whether there really wasn't some tissue protection that was involved with this. And previously, we had seen with some of our rats that when a couple of them, when we went to get a bag we had been measuring the lethal dose. Some minutes later, the rat had not moved, but it was up and running around. So they really can last a long time under these really high concentrations of anesthetics that we can achieve with these. We haven't studied that formally, whether there's any real protection or not, but it's an intriguing possibility. In order to go on with these studies, we wanted to create a formulation that didn't elicit histamine release. And it was a long series of studies, but we ended up discovering that the agent that was causing the histamine release seemed to be the M5F13, and one of the other molecules that Sandra made, M1F13, did not cause histamine release. And this is a much smaller hydrocarbon end of the molecule. The histamine release, we think, is by something called CARPA, complement-mediated anaphylactoid reaction. I'm told by others that CARPA is, in the drug discovery world, well known to happen to dogs and pigs, and it shouldn't prevent us from continuing to make these for use in humans. Nevertheless, just because it doesn't seem like a good idea to have something that activates complement, we wanted to make an emulsion that doesn't have complement activation. So Sandra made these emulsions with smaller hydrocarbon ends. This one turned out to be quite stable with two fluorocarbon tails and the PEG on the outside. And this had a stability that was staying right at 200 nanometers for a year. So this is a really important characteristic for a emulsion that you're going to use clinically. You have to be able to have it stay within the safe range of under 500 nanometers for 9 months. So this looks like it's a good one. This other M1F13 isn't as stable. For the first 30 days, it stays down under 300 nanometers. So it's good enough to use experimentally, and so we tested, could we mix them together and do something that was stable enough, and it turns out that it is. So this is the emulsion we used to go on to our next stage. And rather than taking it directly into toxicity studies and trying to move it forward for use in human studies, we decided to try some studies in non-human primates in order to see whether it would cause any allergic type reactions, which we were concerned about since primates have much more similar immune systems to humans compared to dogs or rats. And also we may be able to monitor some of the hemodynamics and how quickly things happen in these animals. So we had access at a primate center at University of Wisconsin to 3 Rhesus macaques that were part of a colony used for reproductive endocrinology research. They'd all been screened. We designed this in 3 phases. The first phase was to test just the polymer emulsion, then to test Sevoflurane emulsion, see if we could intubate the animals without any muscle relaxant as an indication of depth of anesthesia, and zero in on what the right dose of anesthesia is. The second stage, we were going to use that dose of anesthesia to put the animals to sleep, and then infuse it and see how this would work as an infusion, as if it was a continuous infusion, and see what the response is. In the second phase, we found that the blood pressure during the infusion to keep the animals asleep and not reacting to the endotracheal tube was reduced by about half compared to its awake baseline. Now, its awake baseline is a blood pressure cuff on an animal that's restrained in a chair and not happy about being there. So it still is within a normal but low normal range for these animals, so we could keep them asleep. And then in phase 3, when we wanted to test how quickly the emulsions would cause hemodynamic effects, we designed it to put the animals to sleep, maintain them on an inhaled sevoflurane steady baseline for some time, and then give a painful stimulus and see whether or not the painful stimulus would cause blood pressure to go up and whether we could attenuate that rise in blood pressure with just a small single bolus administration. And we found that we could induce anesthesia with about the same number of milliliters per kilogram of 20% sevoflurane, about 0.4 milliliters per kilogram. And so that's a reasonable dose that could be used, or a reasonable volume that could be used in humans. If we give a single bolus, the animal is awakened very rapidly, and it's able to ablate the hemodynamic response. We also tested, I'll show you some more about the hemodynamic response, but we were worried about histamine release and any anaphylactic reaction. We saw no histamine release and no rises in histamine concentration in these animals. We also did study immunoglobulins and didn't find any IgG, but did find a rise in IgM in 2 of the animals. I'm not sure that that's related to anything that we saw, but and it didn't happen in all of the animals. And this was the hemodynamic consequences. When we had an animal under stable inhaled sevoflurane and we used a painful stimulus, and this was a stimulus that was basically a nerve function monitor that we would put on wrist, that we put either on the abdomen or down on the sural nerve of the animal, and gave it tetanus. And with that tetanus, it was enough of a painful stimulus that you can see the blood pressure, the mean blood pressure rose to over double over the course of a few tens of seconds and then came back down. If we gave just the IV sevoflurane bolus dose, the mean blood pressure did fall here under anesthesia from just over 70 to just over 50. So we do see a little bit of a drop in blood pressure with a single bolus dose of about 1/5 of the intubating dose of sevoflurane. And when we did the 2 things together, we gave a bolus dose and then the painful stimulus. The mean blood pressure didn't respond much here. It looks like it drifted up. We don't know whether or not this was caused by the painful stimulus not being completely ablated. We repeated this, but unfortunately, with the next animal, we had hemodynamic collapse with induction. Now, this animal was induced in a non-standard way by the veterinary technicians away from where it was being monitored, as they usually do. But this really gave us pause. We retooled, went back, monitored closely. In another animal, we saw some arrhythmias. And it has caused us to think about what the next thing to do is. We stopped the studies with the primates to try to understand why did we have hemodynamic collapse. And the best guess that we have is that we're having a different situation with intravenous administration compared to inhaled. With inhaled administration of a volatile anesthetic, as a patient, typically child, gets deeper, respiration is suppressed, and that limits the rate of uptake of the drug and gives a certain safety factor. With intravenous administration, the more ventilation is suppressed, the less the inhaled agent, the intravenously injected volatile agent is exhaled. Usually you give this intravenously, and a lot of it goes out of the lungs immediately. If you stop breathing, then the rate of concentration rise is not going to be limited, it's going to be accelerated. So this becomes an unstable situation. So it's as if we're walking on a knife edge when we use these intravenously as opposed to inhaled. And so that doesn't mean that it's not possible to use it safely, but we have to define how quickly is this released, what are the doses we can give safely. Once we figure that out, then we do still have to do the rest of the toxicity studies to move it to FDA approval. And it is a new excipient. Perfluorooctyl bromide, the stabilizing agent, is accepted by the FDA for giving to humans, but the surfactant is a new substance that now, as an excipient, may be able to be tested or approved through an accelerated pathway. So those are the next steps that we have, and I'm happy with that to conclude the presentation and take any questions. And here are the people who did all the work.
Any questions on this from the audience?
I like your idea very much because you also seem to think that there must be something better than a circuit system. But one question, it's obvious for the induction phase that when you give it intravenously, you will be much more efficient. What about the maintenance phase? I know it's maybe too early because the system is not yet available in humans, but from the previous data, when you, let's say in a patient who has got a minute volume of 10 liters per minute, when you have a circuit system with a fresh gas flow, let's say 1 liter per minute, as a comparator, and when you give it IV in the maintenance phase, what fresh gas flow would the consumption correspond to? What do you think? Would it be 1 liter? Would it be fresh gas flow 2 liters?
Well, it depends on how much is being breathed out. At maintenance phase, you have to be able to give
in
just
an open system.
In an open
IV
system.
plus open system.
That's right. So it would be a very inefficient way to give anesthesia in an open system. But it wouldn't be so hard to give it in a completely closed system and monitor the untitled concentration. And so if this ever becomes useful, that's how I imagine it being useful. And then open the system up in order to allow the patient to recover.
I have a question on this. In a maintenance stage, then, the more you ventilate the patient, the more you're going to blow off. So let's say you're infusing this at a constant rate. Every time you adjust the minute volume, aren't you going to also have to adjust the infusion rate to compensate for that to hold a steady
That's
mac?
right. You would if it was an open system. But like I said, I can't imagine it being useful in an open system. It may be necessary to use it in an open system if there's not a closed circle system as a portable anesthesia, but it'd be a lot easier to create a portable anesthesia system that consists only of a hand ventilator and a CO2 absorber, and then you could still use it like that.
Any other questions? I had one more question, but again, I had been, as you were talking, I had been thinking about this in an open system, but you mentioned that in rat studies that the MAC level was slightly lower with an IV than it is inhaled. Any thoughts on why that would be, or why the MAC would be different for that?
Well, it is a complicated kinetics. When the drug is given intravenously, some of it goes out into the lungs, but some of it gets past the lungs. It must be the low, that's right, like through a shunt. It must get through the shunt. Then it gets to its effective site, and it gets recirculated. So it depends on how much is being recirculated and given compared to how much is being exhaled. Exhaled doesn't necessarily mean completely immediately lost. Even if it's not a circle system, it may be that it isn't gone during the next cycle. And so it's a matter of how much the gas is being diluted by the inspiration in an open system versus how much is being lost from the blood to the alveoli and then.
Exactly. So the way the MAC experiments were first done, we were pushing gas into the dead space and watching
So the
it
cascade
reflect.
is to go down, and
we're
now the
going the other
cascade
way.
is going up.
Exactly. So the
Right.
air pushes lower as opposed to being pulled higher. So it's interesting kinetics,
Yeah.
if not for anything else. Any other questions from the audience? Very interesting work.
Okay, thank you.